Thanks very much. Look, just before I start with my presentation, and hopefully it will come up there, given that I'm going to be talking about prevention and treatment, again, as a broad overview before the other speakers come, I'm going to use a little quote that I often use when I do presentations. Having worked in the drug field for nearly 30 years, which means I'm old, on the rare occasions that my wife and I get invited out for dinner, people say, "Does he drink?" on the assumption that they're going to have to hide the grog away. And I often like to clear up my views about alcohol, one of our favorite drugs, but using the words of a politician, because we know politicians are always unambiguous and straight to the point and don't compromise. And this particular American senator sums up very well what I think about what used to be my national drink, and that's whiskey. That particular point is to the person who referred to me as an Englishman over lunch. And he said, "All right, you've asked how I feel about whiskey. Well, here's how I stand on the question. If when you say whiskey, you mean the poison scourge, the bloody monster that defiles innocence, yea, literally takes the bread from the mouths of little children. If you mean the evil drink that topples a Christian man and woman from the pinnacles of righteous, gracious living into the bottomless pit of degradation and despair and helplessness and hopelessness, then I am against it with all of my power." But, some of you be pleased to hear, thinking, who invited him? But, if when you say whiskey, you mean the oil of conversation, the philosophic wine, the stuff allows good fellows to get together, that puts laughter on their lips and the warm glow of contentment in their eyes. If you mean Christmas cheer, if you mean the drink that puts a spring in the old gentleman's step on a frosty morning, if you mean the drink that enables a man to magnify his joy and his happiness and to forget, if only for a little while, life's great tragedies and heartbreaks and sorrows, if you mean that drink, the sale of which pours into our treasuries untold millions of dollars, which are used to provide tender care for our crippled, aged, and infirm, to build highways, schools, and hospitals, then I am in favor of it. This is my stand. I will not compromise. I will not retreat from it. And therein he sums up the challenge that we have when we stand here and say, well, we're going to talk about prevention and public health issues. It's very easy when you work in a treatment service to say, why would anybody do that to themselves? But we have to recognize, as well as the harms that can arise from drug use, the functions that drug use might serve at an individual, at a societal, at a cultural level. And we need to constantly remind ourselves of that. So, with my little party piece done, I'll turn this machine on. So, this is a broad overview, I hope. Work. Aha! Too good now. So, citing Wayne Hall from some time ago, when Wayne said that the public health impact of cannabis has been, to a large extent, neglected. And we actually need to do much more about the impact of cannabis use particularly in relation to young people. And we've heard from various speakers over the last couple of days that there are particular concerns that we might have. This doesn't meant to be totally inclusive, but they include things like the risks of early onset use, the concerns that we might have about substantial increases in the frequency with which some people use. So there's the people who put the joint in the cupboard to bring out on a special occasion, and there's the people who might have that joint finished before breakfast. And then, of course, there's the issue that we don't have a strong evidence base, even though there's a demand that we do more in public health that's specific to cannabis. And we've got to admit, we've not been particularly good at getting those who might benefit from treatment into treatment, and the outcomes are modest. Now, I don't want that to give us a nasty taste, but just to reflect where we're at, I think. So we need to remind ourselves why we do it, and unfortunately, everybody's got the simple reason why people might use drugs. This is why I drink. And of course, these very simple explanations of drug use often fail to hit the mark. Yes, some people might use drugs because of traumatic experiences, intolerable circumstances, but some people use drugs because they enjoy them, because they're fun. And if we forget those basic understandings of the broad range of things that influence drug use, we'll fail to understand the best ways to respond. And Paglia and Room and various others have said this much better than I possibly can. But if we view prevention as something to be sold to youth, those selling it often fail to understand the market. And one of the important things is that people who are middle-aged or past middle age, often who work in the health industry, like myself, might think health is really, really important. But health might not be a prime motivator for young people. And Andy Capp, those of you who remember Andy Capp, can sum it up very well. Andy Capp's a sort of archetypal English working class hero. There were cartoons, and he was never seen without a fag in his mouth and a pint in his hand. And there's a lovely scenario where he goes to his doctor, and his doctor says, "Andy, do you realize that people who don't eat fatty food and don't smoke and who don't drink more than 2 standard drinks a day live an extra 20 years? And Andy Capp says, "Serves them right." Because he'd rather be dead than live like that. Maybe me telling a 16-year-old that if they smoke tobacco, they might get cancer when they're 72, might not have the sort of impact that I might hope. So whilst some of us think health is important, and it is important for people to have information about health, we might sell it better message is better if we think about reputation enhancement, if we think about impact on schooling or education, or impact, as the judge said, on ability to go to a country of their choice. Don't know why she picked Australia. So where does the public health model take us? Well, there's various definitions of what public health is, but all of the public health models say that it's not just important to delay or prevent use in any strategy. It's also important to prevent or to delay use, particularly because of the impact that we increasingly are becoming aware of cannabis use on the developing bodies and brains. If that's the case, and the evidence strongly suggests it is from a biological and from a lot of the research that's becoming available to us from New Zealand and Australia and other countries, that tells us that that's something we must firmly address in our interventions. Other models of prevention and public health tell us that we don't just need to target the whole population, we might need to target specific groups. So we might need to select or might have particular but the point being that we're going to need a variety of different sorts of prevention and public health activities to match the needs of the various individuals and groups and communities and needs and concerns that we have in our broad communities. And then I come to the question that consistently the evidence tells us that we shouldn't just focus on trying to prevent use. We should be focusing on preventing some of the harms that specifically arise from use. But how we actually do that is not always clear. So that tells us that effective prevention and public health in relation to cannabis needs to cover universal strategies for the whole community, indicated strategies for people who are clearly at higher risk, for example, young people. And we need to have a broad range of approaches that are interconnected. The other thing that the evidence tells us in public health is that drug use arises from an interaction between risk factors and protective factors. So there are risk factors such as people who have troubled early lives, people who live in an environment where drugs are readily available, people whose peers are drug users are much more at risk of becoming enmeshed in problematic drug use. On the other hand, young people who are well connected to school, who are well connected to community, who are well connected to adults, are at lower risk. People who live in families where their families are supportive, where there's good communication, and so on, are at lower risk. Unfortunately, these models don't, for me, translate into evidence of effective cannabis public health strategies. I find it difficult to identify cannabis strategies that demonstrate a strong connection to a risk protection model. I find it difficult to see public health strategies in relation to cannabis that actually don't just try and prevent use, but try and also prevent harm, try and prevent escalation of use. I find it difficult to see a connection between some of the strategies we use in relation to cannabis and the connectedness to tobacco and alcohol use. And whilst I acknowledge what David's comment about in the studies that he's done, there's not that connection. When you see people in a clinical setting, there often is a strong connection between people who are using cannabis heavily and using alcohol heavily. Have these sorts of elements that the research and public health models tell us are critical, have they influenced public health strategies in relation to cannabis? Unfortunately, not. Has a public health approach strongly influenced policy? Well, I think it hasn't. So we need to recognize that I think that a public health approach to cannabis, as I understand public health, it's still relatively neglected. The other thing that we need to be mindful of is we shouldn't just be drug focused. If drug use arises for some people in a context of poverty, intolerance, discrimination, intolerable life circumstances, then not to address those issues is tantamount to victim blaming. Not to address those issues is also ignores the relationship. Yes, cannabis use, early onset cannabis use does predict educational underattainment. On the other hand, separation from quality education can also predict heavy cannabis use. So I'm just raising these as a broad context. Now, does drug policy matter? Well, despite the different policies that different governments in different countries have used, there doesn't seem to be a connection between drug policy and drug law and patterns of use in the community. It seems almost independent of it. When we had changes to the drug laws in relation to cannabis use in Western Australia, the patterns of use continued to go down. The frequency, the prevalence of use continued to go down, irrespective of what happened in the changes in law. It mirrored changes in patterns of use in other jurisdictions where they hadn't had the changes in law. The other thing is that often politicians and members of the community ignore the fact that drug policy can actually make things worse as well as potentially make things better. Here's an illustration of how you could make things worse. This is from almost 100 years ago in the United States. Some of you will have seen this poster. It's a print media campaign. It was in the 1920s and 30s. As you can see, it's a daring drug expose with shame, horror, and despair, and the gentleman's injecting something into the scantily clad lady's arm. Apparently marijuana. Now, if you're not sure about this, go and get some budgie seed and some lawn clippings and try and inject it. You'll get a sore and lumpy arm. So one of the first things we need to do in our public health is make sure that what we do is evidence-informed, evidence-based. But ignoring that little error, I'm sure you're all aware it's a weed with roots in hell, not recommended for children. It creates misery. If you inject it, it creates a lot of misery. It's a smoke that gets in youth's eyes. It creates lust, crime, sorrow, hate, shame, and despair. And next to this scantily clad lady, who's looking a bit angry now because she's got a lumpy arm, it says, what happens at marijuana parties? Well, if you didn't know, weird orgies, wild parties and unleashed passions. I'll have 2.5 kilos, please. If your intent there is to dissuade me from use, sorry. And it just reminds us that when we're developing policy, prevention, public health strategies, treatment, we should always ask the question, how might we make things worse, as well as how might we make things better? So, there's no clear link between cannabis policy in many countries and drug use. In many countries, policy and related strategies is largely driven by legal considerations and rather than a public health concern. So what options might be available to us? Well, the public health domain tells us we might invest in mass media campaigns, and these are often popular preventives. They're more popular than they are effective, although having said that, a lot of the research on mass media campaigns in the drug field is on very poorly funded, poorly resourced, short-term interventions that aren't coupled to anything. Whereas we do see, for me anyway, the value of a mass media campaign that's enduring and supported by random breath testing. It's been going on for 20 years, it's well-resourced, it's repeated. Mass media campaigns have had a significant role in driving some of the responses to tobacco use. And for me, mass media campaigns, I don't expect them to stop people using drugs. But what they can do is provide a basis on which we have more informed community and political debate and responses. So effective mass media campaigns, the research does tell us, are well-resourced, enduring, have a clearly defined audience, and provide a credible message. I can't think of any cannabis mass media campaigns that would actually fit that criteria, so it's not surprising that they haven't been that effective. So they might be best conceived as a component of a multifaceted approach. You might help set an agenda with a mass media campaign, increase awareness and increase support for particular activities. They also have the potential for unintended consequences, as per the poster I put up. For example, they can contribute to stigmatization and marginalization. They can also create interest where none previously existed. There was a wonderful one in Paisley in Scotland where I used to work, and on the front page of the newspaper it said, "Children are eating these mushrooms," and there was a picture of the mushroom, and then there was a picture of the field where the mushrooms were growing in, and then there was a picture of the map where the field was. The next day, but for example, in the US, it was found that greater exposure to anti-drug advertisements was associated with an increase in a perception of how many of our peers were using drugs. And that sort of normalization, if you think everybody else is doing it, maybe I should as well. And we know a lot of young people overestimate whether their peers use, overestimate how much their peers use, and that in itself contributes to the likelihood that they might use and use more. So we shouldn't assume that mass media campaigns do good. We can also look at community mobilization approaches, and these have been very effective. Harold Holder's work in relation to alcohol has demonstrated how you can bring communities on side. We've seen some examples of that in relation to alcohol in Western Australia, where we've seen massive reductions in alcohol-related harm, emergency department admissions, and so on. 50% reduction in sexually transmitted diseases in communities where the whole community is mobilized. We haven't seen such examples really to a large extent in relation to cannabis. School-based prevention activities. Most school-based prevention activities are not particularly effective. And they're usually more commonly used with the more prevalent drugs, alcohol, tobacco, and cannabis. And of course, they miss the people whom you might be most concerned about. So if you run school-based prevention programs, the people who aren't at school aren't getting exposed to them. That's not a reason not to do them, but it's a reason to recognize that you might be missing the people who are most at need. But there is evidence that they do have some impact, and in fact, some of the work that Mary Thiessen at NDARC and her colleagues have been doing in relation to the climate schools intervention has demonstrated that a delivery of an internet-based program to students actually resulted in a randomized controlled trial in a significant reduction in cannabis use in young people. So there may be a role for school-based prevention activities, but as Jeff Munro from the ADF, Australian Drug Foundation, has said, we shouldn't set fantastic objectives for schools. If drug use comes out of availability in the community and poverty and trauma experiences, you can't expect a few hours school education to fix it, but school education has a role. And of course, children have a right to information. Doesn't necessarily mean they'll do exactly what you want them to do, but they have a right to access to information. There may be a role for peer-based interventions, given that many cannabis consumers don't come into contact with our services, maybe by exploring how we can use peers. Often they do learn about drug use from peers. So how do we marshal that to ensure that people are more informed about what the risks might be and how to respond to those risks? But there's not much evidence in relation to specifically cannabis. Family interventions may have a role, and for example, young people, particularly females, seem to be responsive to what their parents think. Now, that doesn't mean they won't use, but it seems to have an impact on excessive, higher risk use. So there's a broad range of prevention strategies, and then of course we might want to target using in risky circumstances. So what are we doing about reducing cannabis use and driving risks, or workplace and cannabis use risks, or preventing risks for current users? And in fact, I've seen Normal have distributed some information that they're putting out about safer use. So the challenge for us is to build an evidence base, but also not to rely on single strategies, but to try and develop a multifaceted approach that's well-resourced and enduring. And then treatment. While, and this is from colleagues here and in the States, sorry, here, I think I'm in Australia again, in this part of the world and in the States, people like Peter Gates, who works at NICPIC in NDARC in the University of New South Wales. Whilst it is fairly prevalent, whilst there's a lot of people who are actually in need of treatment, only a very small proportion of people actually come into contact with treatment. And often they don't stay for very long. And it's because it's too hard, treatment services aren't accessible, they don't know what the options are, they feel stigmatized by putting their hand up and coming forward for treatment. This is a real challenge. As Wayne has said, there's increasing numbers of people who are dependent on cannabis who would benefit from treatment, but very few of them come into contact with our treatment services. The other problem we have is many clinicians who work out there don't think cannabis is a problem either. Oh, it's only cannabis. What about alcohol? What about amphetamine? We're not concerned about it. It's dismissed as being a trivial concern. And the evidence base that we've got is a relatively recent evidence base. It's building, but the specific treatment trials are only 15, 20 years old. The pharmacotherapies are very limited. And the strongest evidence base in treatment is for brief interventions, motivational enhancement therapy, CBT, and contingency management. So those who do enter treatment are often more severe, often have multiple problems, and they'd actually prefer to see a GP rather than come into a drug treatment services. But I don't know, I'm not surprised by that. If I had a drug problem, I wouldn't go to a drug treatment service. With all respect to the drug treatment services I've worked in, I'd want to talk to my GP or someone who's not, I don't want to walk through a door that says junkies this way. It's not what I want to do. And whether that's an accurate or fair representation, unfortunately, it's a view that a perception that many have. The numbers of people entering treatment are significantly increasing. In Australia, that's probably, at least in part, because more people are being coerced or diverted into treatment. But as Wayne said, it's not just that, because it's happening in countries where they don't rely on coercion and diversion for cannabis use. It's probably reflecting some of the things that we've been hearing in the last few days. So, brief interventions. The evidence tells us that brief interventions can be effective. Peter Gates and colleagues, for example, replicating work that had been done in the States, show that a very brief 4-session intervention can have an impact based on motivational interviewing and CBT. But the evidence from most of the studies tells us that you might reduce the frequency of use, you might reduce the circumstances in which people might use cannabis, but you don't necessarily reduce the quantity that they use. And as I said, motivational enhancement therapy, CBT, and contingency management are the most effective according to the evidence, and in fact are most effective when they're combined. But again, the evidence tells us that the treatment outcomes are modest, and as Wayne said, probably similar to what we're finding with alcohol. Most people who go into treatment for alcohol don't successfully continually abstain. But there are a broad range of successful outcomes in terms of reduced harms, reduced frequency of use, and so on. So the conservative conclusion about treatment is only a minority enter treatment, few achieve abstinence, but it's still better than not entering treatment. So, and the final treatment that's coming to the fore at the moment is multidimensional family therapy, and there's studies done in the States and then replicated in Europe, which have demonstrated that they have a superior outcome even compared to motivational interviewing and CBT. However, I suspect that that might be an intensity factor rather than the specifics of the intervention. And in fact, when you control for time, the superiority of MDFT disappeared. But again, you can see that still still a significant proportion of people still met the criteria for cannabis dependence and abuse 12 months after treatment. What's CBT? Cognitive behavior therapy. Yeah, sorry. So, to end, the relative neglect of cannabis has left us some challenges. The responses that we have are still dominated by a legal perspective as opposed to a public health perspective. And that's a significant failing. It doesn't mean there isn't a role for a legal consideration. It just means that we don't pay sufficient attention to the public health issues. The rates of harm and use in our community seem independent to much of the policy agendas that we actually set. And in fact, most politicians and communities give insufficient attention to, could our strategy make things worse? We have good ideas about the risk and protective factors, but we don't use that information to build effective public health strategies to respond to cannabis use. The evidence base about treatment is limited, but it's building and it's consistent and it's similar to what we found in relation to alcohol. But the problem we have is that many people who would benefit from treatment don't perceive themselves at risk or don't see the treatment that's offered as attractive or accessible. And so that's where we're at. And then I'd like to leave us with two key questions that come out of some of the other debates that are going on in the conference over the last few days and tomorrow. What are the public health implications of what some people, for example, Nadia yesterday and Wayne, what are the public health implications of the knowledge we have now that not all cannabis is the same? You know, if there are increases in THC and decreases in CBD, how do we use that information to design more effective public health strategies? And then secondly, given that there's a very public debate going on about changes to the law, and in some jurisdictions in the United States and elsewhere, they're changing the law to legalize cannabis, or the debate about the alleged medical benefits of cannabis and the implications of that, what implications does that have for how we design our public health messages? And I'll leave those questions with you. Thanks very much.
Do we have some questions, please? Put your hand up if you've got some questions. Can't see anything. One question down here, thanks. We've got a mic. We've got mics ready and running around, or you'll just stand up and shout. Oh, there you go.
I'd like to turn your last question around. The potential changes to the laws which are being discussed in various countries, what assistance may they provide to public health?
Oh, well, it's not turning it round. I said, what are the implications? Yeah. So, and I think for me, it's an open question. We don't know. And I think the changes, for example, in various states in the US, I would hope, and David referred to this challenge earlier, that that they're carefully evaluated so that we learn from these experiences both what the benefits might be, but also what the unintended adverse consequences might be. We then need to use that information in the design of our public health responses, irrespective of what the legislative framework is. Clearly, some people will experience harm from regular excessive use of cannabis, or if they use it at an early onset. What does that debate that's going on now, how does that influence the way in which we design our public health strategies. And that question for me is still open because I don't know what's going to happen in those jurisdictions.
Yeah.
No. I think some things will get better and some things will get worse, possibly, but I don't know. I think we actually have to monitor it.
Question from Malcolm X there. Yep. Sorry, can we get have we got microphones? Because it's a lot better if we have them. Everyone else can hear. Sorry.
I'm walking to the edge of the stage because I'm blinded by the light, so I can see you better. I'm not trying to.
Yeah, just in relation to Western Australia and the change in cannabis policy a few years ago, and I understand that built into that was a set of analyses around the outcomes of those policy changes. Were they effective? Did you get some good data out of those?
I think what the analyses told us was that the change to the law didn't make much difference. Cannabis use was in Western Australia and the rest of Australia was at a height, prevalence of use was at a height in 1998 and started coming down subsequent to that. And continued to come down after the change in law in 2003 and continued to come down in 2007 and then went up a little bit in 2010. But that same pattern was exhibited across Australia. So what that tells me is the law didn't make much difference. And again, given that only 3 to 4% of the population actually find themselves, of consumers, find themselves apprehended by the police, I'm not surprised by that. Most people say that getting and I think David's work shows the same, getting a criminal being seen by the police using cannabis doesn't actually make much difference to what you do subsequently. And so I'm not surprised that the change to law didn't make any difference. And what we've got to remember is that what happened was it was the severity of the consequence. We already had a cautioning system in Western Australia up until 2003, initiated by the previous government. Then Labour came in and brought in this decriminalisation, and a lot of people argued that that was legalisation, but it wasn't. It was still prohibited, but the consequence was that the police officer would give you an expiation notice and you could deal with that by paying a fine or attending a counselling service. And the problem with the system was that the fines enforcement system didn't work very well. So they didn't follow people up who didn't expiate. And they used this as an argument that the system was failing, whereas it was actually the fines enforcement system that was failing. And then they also, when the Conservative government came in, they said that they changed the law back, but they still give a caution, but you're only allowed one caution, whereas under the Labour government system, you were allowed 3 expiation notices. So there wasn't that much change at the end of the day, but all the research tells us is it didn't make much difference.
More questions? No, we can move on to the... I just have one last question. Just, is it possible there's a third kind of whiskey? Because I think I've had somewhere the first half of the bottle is the happy stuff, then they do something to the second half of the bottle and make it the angry one? Because
It's a bit like people saying, I only feel crap when I mix my drinks. But of course, the only way you can mix your drinks is by drinking more. You never mix your drinks having one. So everybody always blames the whiskey that they had at the end of the night, forgetting that there was the 23 other drinks that they had before they had the whiskey.
Someone spiked my 17th drink, definitely, that's what happened. Thank you very much, Professor Allsop.